Hello, everyone. We're just going to wait a minute or two to give people time to log into the call. We'll be starting shortly. We'll give it just a couple more seconds, give people a little more time to log on and get going soon. Good morning, good afternoon, and maybe for some even good evening. This is Ken Mayer. I'm a part of the Harvard Center for AIDS Research. On behalf of my co-chair, Dr. Patrick Sullivan of the Emory Center for AIDS Research, we're delighted to invite you here today to the Antiretroviral Prevention Inter-CFAR Scientific Working Group. We're very fortunate to have with us today Dr. Mark Mrozynski. Mark is a professor of pathology and medicine at Johns Hopkins University School of Medicine. He's co-PI of the HB10 Laboratory Center. He's a board-certified clinical chemist, and he directs the Clinical Pharmacology Analytical Lab at Johns Hopkins. He's Associate Division Director of Clinical Chemistry at Johns Hopkins, and he runs the core for their CFAR as well for their clinical laboratory core. He's really been one of the go-to people in understanding the meaning of the different assays we use to understand adherence to antiretrovirals. He's a master of a number of different technologies, including specific pharmacologic assays, pharmacogenetic studies, as well as mass spec and clinical laboratory medicine. And he has really been seminal in leading a lot of different analyses. So we're very fortunate to have him with us today to be talking about the pharmacologic evaluation of HIV PrEP drugs, and particularly with consideration for long-acting agents. Uh, Please put your questions in the chat as Mark proceeds with this talk. We'll have time for Q&A at the end of the session, moderated by Patrick Sullivan, and we look forward to the presentation. Thank you for being here today, Mark.
Great. Thanks so much. I want to thank Dr. Sullivan and Mayer for the opportunity to present today. And as Ken mentioned, today I'll discuss the pharmacologic evaluation of HIV prevention drugs, specifically focusing on considerations for long-acting agents. I have no relevant disclosures. As a bit of an introduction to expand on what Ken mentioned, my lab, which includes the Clinical Pharmacology Analytical Laboratory Service Center, has a number of interconnected research interests. So our group is focused on the development, validation, and implementation of bioanalytical tools to characterize drug pharmacology. We've developed assays to assess drug pharmacokinetics and pharmacodynamics, and we actually perform clinical pharmacogenomics testing for our health system. We're also interested in understanding the multi-compartment pharmacology of topical and long-acting drugs as related to HIV prevention, and in characterizing PrEP pharmacology in understudied and underserved populations. We support preclinical, clinical, and registrational trials, and we serve as the primary pharmacology resource for the HPTN, the ATN, RJHU CFAR, as well as the Infectious Disease Clinical Research Consortium. Collaboration with multiple partners allows us to work effectively and synergistically to contribute to the HIV prevention space and the larger anti-infective space. So the objectives of today's discussion are threefold. First, we'll focus on the overarching pharmacologic considerations for long-acting drug delivery strategies. We'll then discuss our understanding of long-acting cabotegravir as an HIV pre-exposure prophylaxis agent, and then we'll detail several PK-focused sub-studies and ancillary assessments conducted within the long-acting CAB efficacy trials. The overall goal of this presentation is to illustrate how pharmacology is central to trial outcomes and how PK assessments can be incorporated into larger clinical efficacy trials. So as we know, there's a growing and diverse suite of biomedical HIV PrEP options available. These range from daily oral fixed-dose formulations like Truvada and Descovy to monthly Dipivirine vaginal rings to longer-acting intramuscular and subcutaneous agents. Today, we'll primarily focus on long-acting cabotegravir for HIV prevention, which I think serves as a prototype example for a long-acting agent. And near the end of the presentation, we'll also briefly touch on lenacapavir for HIV prevention. So traditionally, pharmacokinetics followed by oral dosing typically involves the relatively quick absorption of a drug into systemic circulation, leading to a fairly predictable peak plasma concentration and a subsequent decline as the drug is eliminated from the body with a consistent half-life. In contrast, absorption-limited pharmacokinetics, also known as flip-flop PK, occurs when the rate of drug absorption is significantly slower than its rate of elimination. This leads to delayed peak plasma concentrations. In this scenario, the time to reach peak concentrations is extended, resulting in a longer apparent elimination half-life than you would typically see based on or expect based on the drug's clearance. Absorption-limited kinetics alters the usual PK profile, causing this prolonged decline in plasma concentrations rather than this smooth curve like when you transition from peak to elimination. Factors that can contribute to absorption-limited kinetics include formulation characteristics, drug solubility, and delivery modality, as we see with long-acting products. Understanding this phenomenon is important for optimizing dosing regimens, predicting therapeutic effects, and ensuring patient safety. Generically, this equation can be used to calculate plasma concentrations at a given time, given PK parameters like dose, volume of distribution, and an understanding of both absorption and elimination rate constants. So as we know, long-acting drug delivery modalities offer several benefits over oral medications, particularly in terms of adherence, convenience, and potentially therapeutic efficacy. So one of the primary advantages is that long-acting delivery systems provide consistent exposure over an extended period, thereby reducing the frequency of dosing and improving adherence. Further, long-acting products can minimize the peaks and troughs in drug concentrations associated with oral dosing, resulting in more stable therapeutic effects over time. For example, long-acting products can be effective and useful as art, as maintaining stable drug concentrations can ensure efficacy and prevent viremia. So as we think about long-acting products, what attributes may influence downstream study design? Categories, for example, focus on formulation science, pharmacology, efficacy, safety, and patient-specific factors all come to mind. With regards to formulation, the specific product composition, excipients present, and manufacturing processes can influence not only product stability and shelf life, but all of these other downstream categories relevant to study design. PK considerations that are always at the outset include route and location of delivery and proposed dosing frequency, as well as the potential for drug accumulation and drug-drug, drug-hormone, drug-food interactions. Many of these are likely to be characterized and optimized in the product development pipeline in preclinical and early phase clinical studies. However, these should also be considered in later phase efficacy trials. When we think about efficacy, we're really thinking about the therapeutic window, as well as the potential pharmacologic contributors to treatment failure. In the anti-infective space, a key consideration associated with treatment failure is the emergence of drug resistance. Potential toxicity and management of adverse events are critical and may influence the frequency of study visits or points of contact with a participant. And lastly, patient-specific factors like acceptability, product choice, and preferences, as well as self-perceived risk, are also important considerations when thinking about design. For long-acting products, the LEAP program is a helpful resource that can aid in product design and selection. LEAP, which is the Long-Acting Extended-Release Antiretroviral Research Resource Program, which is a bit of a mouthful. It's an NIH-funded initiative that focuses on the pharmacology of long-acting products for HIV, tuberculosis, viral hepatitis, and others. The program supports the development of these treatments via a systematic framework that includes landscape and gap analyses, in silico modeling, as well as the evaluation of the preclinical and clinical outcomes of studies involving long-acting products to improve drug formulation and delivery characteristics. So the LEAD program has served as a really helpful resource in gaining insight on the current landscape and priorities around long-acting drugs and delivery systems, not just in the HIV space, but also for TB, hepatitis, and malaria. So now that we have a background on some of the attributes of long-acting products, let's delve into long-acting cabotegravir as our prototype example. So cabotegravir, structure is shown here, is an integrase strand transfer inhibitor that has physiochemical characteristics that make it amenable to formulation as a long-acting nanosuspension, including low aqueous solubility and a high melting point. These characteristics promote CAB stability when it's formulated as a crystalline nanosuspension. Further, CAB exhibits high antiviral potency, has a long systemic half-life, and slow metabolic activity. So these characteristics allow for prolonged antiviral activity once the drug is released from its intramuscular depot. Based on in vitro data, CAB's protein-adjusted 90% inhibitory concentration, or PAIC90, is 166 nanograms per mil. Long-acting CAB monotherapy was evaluated in non-human primates via intravaginal and intrarectal challenge studies. The Kaplan-Meier curve shows the protective capacity of 50 mg per kg of long-acting CAB with repeated intrarectal challenges in blue, which is shown here, as compared to untreated animals in red, shown here. In animals receiving CAB, there was a protective efficacy of 100% when plasma concentrations remained above the 3x PAIC90. Parallel experiments were conducted with intravaginal challenges, with 100% protection associated with plasma concentrations above the 4x PAIC90. So these pharmacologic targets will come into play in the CAB PrEP efficacy trials. We evaluated the pharmacokinetics of long-acting CAB now a number of years ago in the phase 2A HBTN 077 study. Participants were randomized 3-to-1 to CAB or placebo, and for participants randomized to CAB, following a 5-week oral lead-in, they received 600 milligrams of intramuscular CAB injections for 5 cycles, with the first 2 injections separated by 4 weeks, and the rest by 8. The sampling schema involved collection at pre-injection visits, as well as 1 week post-injection to estimate C-tau and C-max respectively. Following cessation of injections, visits occurred every 12 weeks for up to 76 weeks. Concentration time profiles and PK parameters were presented and shown here, and they were stratified by sex. So in the figure, the red data points are females and the blue data points are male. As we can see, we observed high inter-individual variability in both trough and Cmax concentrations across the cohort. We also noted sex-based differences in PK parameters. For example, after the first injection, male participants had significantly higher maximum, trough, and AUC CAB concentrations as compared to female participants. However, trough concentrations following subsequent injections were significantly lower in men than women. So as previously mentioned, long-acting products like CAB exhibit absorption-limited kinetics, in which its concentration time profile is predominantly driven by drug absorption as opposed to elimination. Within 077, the terminal apparent half-life of CAB after cessation of injections was 45 days in males and 60 days in females. Males are shown in the upper panel, females in the lower panel. We also observed that around 1/5 of women had quantifiable CAB concentrations more than a year after their last dose. So as shown on the previous slide, greater drug accumulation in women was observed, as indicated by higher CAB trough concentrations with subsequent injections, resulting in decreased clearance over time. So our colleagues at GSK generated a population pharmacokinetic model for long-acting CAB, and involved 16 treatment or prevention trials, including HBTN 077. The model included more than 23,000 injection events across more than 1,600 participants. A two-compartment model with first-order absorption and elimination best described the data. And as shown in this figure, the absorption rate constant and bioavailability for oral CAB is distinct from the long-acting depot, which isn't surprising once we sort of understand, again, the absorption limited kinetics with the long-acting product. The contributions of several covariates were evaluated, and unsurprisingly, sex was a significant covariate. The absorption rate constant in women was estimated to be around 51% lower as compared to men, reflecting slower release and delayed accumulation from the intramuscular depot. This obviously bore out in our observations in 077. At steady state, trough concentrations are predicted to be around 32% higher in women, while peak concentrations are predicted to be around 15% lower. Increased BMI and shorter needle length were also associated with decreased exposures in steady-state CAB concentrations. So we've also gained insight into the distribution of CAB into the rectal and female genital compartments. In collaboration with ViiV, we conducted a single intramuscular dose study to understand plasma and tissue CAB exposures over time. Following a single IM injection of CAB, we made several observations. We showed that rectal tissue concentrations, shown in this dark blue-black line, are lower than in the female genital tract, as shown in our green and purple lines. Also, we showed that CAB was quantifiable in cervical tissue for 12 weeks, as compared to 8 weeks in rectal tissue. Adjusted R-squared coefficients from log-log linear regression of plasma and time-matched tissue CAB concentrations were 0.9, 0.78, and 0.79 for rectal, cervical, and vaginal tissue, respectively, demonstrating strong correlations between plasma and tissue concentrations over time. When looking at tissue to plasma ratios, the geometric mean ratio of the tissue to plasma Cmax was 0.2 in cervical tissue and 0.1 in rectal tissue. So the slower systemic decay in plasma and local decay in the female genital compartment may provide some pharmacologic advantages for women, as we've observed greater penetration into the female genital tract and higher trough concentrations over time. As many in the audience are probably aware, the HIV prevention efficacy of long-acting CAB was evaluated in two phase 2b/3 clinical trials, comparing long-acting CAB to daily oral FTDF. HBTN 083 focused on men and transgender women who have sex with men and was conducted at 43 sites across 4 continents and 7 countries with more than 4,500 participants in the intent to treat analysis. HBTN 084 evaluated CAB efficacy in women and was conducted in Eastern and Southern Africa with more than 3,200 participants included in the intent to treat analysis. As a reminder, following early reports of an increased incidence of neural tube defects in women living with HIV during periconceptional exposure to dolutegravir, which is a structural analog of CAB, the use of a modern contraceptive method with a failure rate of less than 2% was incorporated into 084 as an enrollment requirement for inclusion. The study design for both trials included a 5-week oral lead-in in which participants received daily oral CAB or FTDF and placebo pills. During the injection phase of the study, participants received an initial intramuscular injection of 600 milligrams of CAB or placebo, a second injection 4 weeks later, and injections every 8 weeks thereafter. Participants were also supplied with oral FTDF or placebo pills to be taken daily. Participants who discontinued injections or completed the injection phase of the study were offered open-label FTDF for 48 weeks. So the study schedule is summarized herein, and if you look at the bottom panel, arrows denote scheduled injection visits. Across both trials, the protocol specified pharmacologic target was trough CAB concentrations above the 4x PAIC90, which was predicted to be achieved in 80% of participants. So this target was selected based on the previously described non-human primate SHIV challenge studies, and the dosage and dosing strategy were selected to achieve this target for both men and women. 083 and 084 were prematurely stopped by International Data and Safety Monitoring Boards in 2020 as they met their predetermined endpoints. The efficacy findings from the blinded phases of the trials are shown here. HPTN 083 and 084 showed 66% and 91% relative risk reductions of acquiring HIV as compared to FTDF, respectively. So, let's focus a bit on acquisition offense and participants randomized to the CAB arm. To do that, we actually classified the cases based on when viral acquisition occurred in relation to product administration. A cases describe participants who were HIV positive at enrollment. B cases occurred in the background of no CAB administration for at least 6 months prior to the first HIV positive visit. C cases occurred during the oral lead-in. D and DX cases occurred during the injection phase in the background of on-time or at least one delayed injection, respectively. And BR cases occurred after 6 months of no CAB administration, but the participant was HIV positive when CAB was restarted. So for this presentation, obviously, it's important to hone in on the D cases, which are cases that occurred in the background of on-time injections. So before summarizing cases from the blinded and the first unblinded year, let's focus on one illustrative example from 083. So here we're looking at a participant's CAB concentration time profile, so concentration over time from enrollment, contextualized by injection events and virology data. Orange circles denote CAB concentrations. Green lines show the CAB injection events, which were administered on time. The red bar, which is shown here, is the first HIV positive visit, determined using a suite of virology testing at the HBTN-LC. And the blue line is the first site positive visit. Here we can see that drug concentrations remain above target, right? This is the 4x PAC90, and after initiation of injections, concentrations are really where they're supposed to be. We can also see that while we can't define adherence during the oral lead-in, that study product was being used during the oral lead-in, right? Oral CAB pills. HIV was acquired after 7 injections with a very low viral load that was detected at the HBTN-LC at 130 copies per mil. The site detected HIV 112 days later after 2 more injections were given. As shown in the blue shaded region, the participant was linked to care and initiated on ART. So combining the blinded and first unblinded years for both trials, across more than 4,650 person years in 083, there were 34 cases of viral acquisition in the CAB arm, but only 6 occurred in the background of on-time injections, or classified as D cases. In 084, we had 7 characterized infections in this period, but none occurred in the background of on-time injections. The question then to consider is, are there additional implications to viral acquisition in the background of CAB, particularly with regards to HIV drug resistance? During the blinded phase and first unblinded year of 083, major integrase strand resistance associated mutations were detected in 10 of the 16 cases where the first HIV positive visit was within 6 months of the last CAB exposure, including all of those D cases. Integrase strand resistance associated mutations emerged pretty early and when viral loads were low. The median days after that first HIV positive visit, when an InstaRAM was detected, was 38, and the median viral load was 148 copies per mil. However, major InstaRAMs were not observed when that first HIV positive visit was more than 6 months after CAB administration. One area worth briefly mentioning is the utility of RNA testing for persons receiving long-acting CAB for PrEP. So routine RNA testing was built in to the 083 and 084 open label extensions due to delayed detection of infections with traditional HIV antigen antibody testing from the blinded phase of both trials. However, Rafey and Sinead have presented at IAS and CROI on the low positive predictive value of routine RNA testing and the low sensitivity of RNA as a screening tool in the background of long-acting CAB. So while it's largely outside of the scope of this presentation, I did want to present current guidance from the IAS USA panel on antiretroviral drugs for treatment and prevention of HIV. For initiation of long-acting CAB, or after a long hiatus, HIV screening should include a lab-based antigen antibody test as well as an RNA test. However, for follow-up routine RNA testing isn't recommended, and a rapid HIV antibody and instrumented antigen antibody test should be performed. So if we take a step back, right, as the PrEP landscape has evolved to include long-acting agents, there's going to be a greater need to characterize contributors to pharmacologic variability and understand reasons for product failure. So while we have a pharmacologic target based on SHIV models, we don't have a definitive correlative protection for long-acting CAB in humans. We sought to estimate a protective threshold based on data from 083. A nested case control study was conducted among 083 participants to investigate the association between plasma CAB concentrations and HIV risk reduction. Model-based CAB plasma concentrations were estimated for participants with confirmed HIV and 4 HIV-negative controls, and they were matched on region, gender, and race. Cases and matched controls were selected irrespective of the receipt of CAB injections or adherence to the dosing schedule. This approach was used because it mitigates bias in selecting only cases and controls who have high adherence to long-acting CAB and allows us to interrogate participants who have variable CAB exposure over time. In this analysis, we had 25 cases and 99 controls. CAB exposure was assessed during the time interval when HIV acquisition was assumed to have occurred. So for adjudicated HIV-positive cases, the window of HIV acquisition was defined as the time between the last HIV-negative and first HIV-positive visit. That same window or exposure period was used to characterize CAB concentrations for corresponding matched HIV-negative controls to ensure comparable time intervals. Using model-generated CAB profiles, which were based on observed data, the primary CAB exposure metric was the estimated minimum CAB concentration during that window of infection. So what was the lowest predicted concentration that occurred between the last HIV-negative and first HIV-positive visit? We categorized our minimum CAB concentrations into 3 groups: below the 1x PaIC90, or less than 166 nanograms per mil, between the 1x and 4x PaIC90, and above the PK target, or the protocol-specified target trough concentration, greater than or equal to the 4x PaIC90. This minimum CAB concentration is assumed to estimate the concentration when a participant was most vulnerable to HIV acquisition. HIV risk was modeled via logistic regression. And in this analysis, the estimated minimum CAB concentration was greater than or equal to 4x of the PaIC90 in 28% of HIV-positive cases, as compared to 75% of matched controls. Minimum CAB concentrations greater than or equal to the 4x PaIC90 were associated with a 93% risk reduction of HIV acquisition, as compared to minimum concentrations less than the 1x PaIC90. Minimum CAB concentrations between the 1x and 4x had an estimated risk reduction of 79%. So looking and leveraging our data from 083, it's pretty consistent with observations made in the non-human primate models and the trough pharmacologic targets applied in the prevention efficacy trials. So beyond leveraging the data from the CAB PrEP efficacy trials to estimate pharmacologic correlates of protection, we've also sought to understand CAB pharmacokinetics in the background of different scenarios, including around the pharmacologic role of the oral lead-in the impact of delayed injection administration, and during pregnancy. So I'd like to briefly highlight some of our findings in each of these areas in the back half of the presentation. So as we know, the oral lead-in for long-acting CAB is now optional, and in the 083 and 084 open label extension studies, most participants elected to forego the oral lead-in. In work led by GSK, and using data from the FLAIR treatment trial, the time to reach target CAB concentrations was evaluated using both observed and simulated PK data. So data in this figure represent observed CAB concentrations 1 week post-injection. As we can see, 1 week after that first injection, CAB plasma concentrations were higher in participants who participated in the oral lead-in, as shown in purple, as compared to participants who did not, as shown in green. However, in both groups, geometric mean concentrations remained above the pharmacologic target of the 4xPAIC90. By 4 weeks after the first injection, geometric mean plasma concentrations were similar in participants regardless of the open label extension of the oral lead-in. Simulated CAB concentrations without the oral lead-in were evaluated for an all-male, a 50% female, and an all-female population to determine the time to reach the PK target for CAB. So to reach that pharmacologic target of the 4xPAIC90 in 80% of individuals without the oral lead-in, it was predicted that it would take 1.2 days in males and 2.8 days in females. Additional simulations predicted that the PK profiles with and without the oral lead-in became overlapping and pretty much identical within 1 to 2 weeks after that first injection. So these data demonstrate that CAB initiation without the oral lead-in does not result in notable delays in reaching PK targets and supports the optional use of the oral lead-in. So we'll now transition to discussing the impact of delayed injections on CAB PK. So we evaluated the impact of injection delays in women, given the slower absorption rate constant and greater accumulation profiles observed in that population, as I showed earlier in this presentation. So 084 was impacted by the SARS-CoV-2 pandemic, and while allowable windows were built into the injection visit schedule, participants on the trial experienced injection delays, including those which occurred outside of allowable windows. So we were therefore interested in understanding the impact of delayed or late injections on CAB drug concentrations. So samples were identified from participants randomized to the CAB study arm who experienced at least one injection delay during the blinded phase of the trial. And we evaluated the impact of a loading dose delay, which occurred between the first and second injections, or bi-monthly delays, which we'll call Q2M delays. It's noted that in this analysis, we're predominantly looking at participants who experienced a single injection delay, not multiple subsequent delays in CAB administration. Of the 1,614 participants randomized to the CAB arm, 194 experienced at least one injection delay during the blinded phase of the trial. There were a total of 224 delay events. 19 occurred as loading dose delays and 205 as Q2M delays. The median time from enrollment for an injection delay to occur was 49 weeks, and the country distribution of delayed injections are summarized herein. The median age, BMI, and weight of this cohort was 25 years, 26.3 kilograms per meter squared, and 68 kilos, respectively. The median duration of a loading dose delay was 63 days, and 100% of participants actually maintained CAB concentrations above the 4xPAIC90 when that loading dose was given 8 to 10 weeks after the initial injection, as opposed to 4 weeks. As you go further out in time, unsurprisingly, the frequency of participants above those thresholds decreases, and by 12 to 14 weeks after the first injection, the majority are falling below the 4xPAIC90. Bi-monthly delays were more common. Median of 3 injections were administered before a bimonthly delay occurred, and the median delay interval was 97 days. So instead of every 18 or every 8 weeks, it was closer to every 14 weeks. For these bimonthly delays, when injections were administered 12 to 14 weeks apart, which was the majority, at least within this cohort, 98% of participants maintained CAB concentrations above the 4xPA IC90. Unsurprisingly, this declined over time, but even when there was a delay of between injections of 16 to 18 weeks, 90% of participants yielded concentrations above the protocol-specified pharmacologic target. So to evaluate the viability of, could a 600 milligram Q3M regimen work in women, simulations were performed using the previously described PopPK model generated by GSK. So simulated exposures with a 600 milligram Q3M dosing regimen in women were compared against a 600 milligram Q2M dosing regimen in men. So in this figure, black lines reflect females and the red lines reflect males on a Q3M and Q2M regimen, respectively. Panel A reflects a CAB-naive population, and panel B is a CAB-experienced population. In both of these figures, simulated drug concentrations are in the background of a 4-week loading dose. So from these simulations, if the loading dose is used, it's predicted that the lower 5th percentile of steady-state concentrations would be higher in both CAB-naive and CAB-exposed females receiving Q3M injections than in males receiving Q2M. The percentage of participants with concentrations above the pharmacologic target was also comparable at around 88% in each group. Additional stipulations were performed in the absence of a loading dose. So if you just went to a Q3M regimen. So panel C is looking at a zero loading CAB-naive population, and panel D is a zero loading CAB-experienced population. Simulations showed that without a loading dose, the lower 5th percentile in CAB-naive women on a 600 milligram Q3M schedule would be lower than that in men on a Q2M. So although these data provide some reassurance around the administration of an isolated delayed CAB injection in women, it's currently not indicated to alter the dosing cadence of the current formulation, and longer-acting formulations for long-acting CAB are currently being pursued. So we'll spend the last few minutes of the CAB story focusing on participants who become pregnant in 084. So as we're aware, there are progressive physiological changes that occur throughout pregnancy that can impact drug pharmacokinetics and pharmacodynamics. For example, pregnancy progressively affects parameters like renal clearance, protein binding, and enzymatic activity, which are critical for determining appropriate drug dosages. So this table just summarizes several of the parameters that may be altered throughout pregnancy and their impact on drug availability, disposition, and clearance. Pregnancy-associated physiological changes can alter PK parameters in a dose-dependent manner, such as the elimination rate constant, which can influence drug clearance and half-life, as well as dose-dependent parameters like volume of distribution and maximum concentrations and exposures. Overall pharmacologic studies during pregnancy are relatively infrequent and tend to be small, as pregnant women are traditionally not included in phase 3 trials. And this results in post hoc evaluation of safety and efficacy after a product is approved. Recently, I think there have been greater efforts for increased representation and inclusion of pregnant women in registrational trials. We saw that through, the 084 open label extension, and I think most recently in Purpose 1. And this figure from Pariente and colleagues summarizes the number of studies conducted among pregnant and lactating people categorized by drug class. And as you can see here, antiretrovirals are sort of at the far end of this graph. And that's really through many of our colleagues across HIV networks, right? Impact, MTN, where a lot of work has been conducted with antiretrovirals during the pregnant and lactating periods. However, we are seeing growth in the evaluation of drug exposure efficacy assessments in other disciplines as well, including antibiotics, antitubercular drugs, and antidepressants. So as previously mentioned, the use of a modern contraceptive method with a failure rate of less than 2% was included in 084 as an additional safety measure. However, pregnancy still occurred. During the blinded phase of the study, 57 pregnancies occurred, 30 in the CAB arm and 27 in the FTDF arm. Women who became pregnant stopped receiving CAB injections, but follow-up visits occurred for safety and PK. So we wanted to characterize CAB exposure in women who became pregnant, particularly in their PK tail. Unsurprisingly, CAB concentrations declined over time, but median concentrations remained above the 4xPAIC90 for 24 weeks after the first positive pregnancy test. And CAB was quantifiable for up to 72 weeks in a subset of participants. We estimated and compared the terminal apparent half-life in HPTN 084 participants with confirmed pregnancy to non-pregnant women from 077. The geometric mean half-life was 53 days among women who became pregnant in 084 as compared to 60 days from non-pregnant women in 077. The differences in half-life were not statistically significant. We also looked at the contribution of several covariates on half-life. Upon regression analysis, no parameter, including baseline BMI or pregnancy status, was associated with these estimates. So during the 084 open label extension, long-acting contraceptive requirements were removed, and pregnant participants on long-acting CAB could consent to continue to receive CAB injections during pregnancy. Prior to this work, the PK of long-acting CAB during the pregnant period had not been robustly described. Thus, within a nested 084 open-label extension substudy, we evaluated the pharmacokinetics of CAB among 75 participants who continued to receive long-acting CAB injections during pregnancy. We also identified 75 participants to be included in a breastfeeding lactation substudy, and that work is currently ongoing. Within the 084 open-label extension, participants could elect to stay on or switch to CAB or switch to FTDF. The majority of participants elected to stay on or switch to CAB. If participants became pregnant while on the open label extension and had prior or current CAB use, they could consent to continue to receive CAB injections during pregnancy. If participants switched to FTDF upon pregnancy confirmation, they continued follow-up through pregnancy for safety and outcomes assessments. A number of selection criteria were employed to identify the cases to include in the PK assessment. Participants who consented to the substudy, obviously, and participants who had pregnancies that resulted in a live birth, stillbirth, or intrauterine demise with a gestational age of at least 36 weeks at the time of outcome were eligible for this analysis, as we really wanted to understand CAB exposures through the third trimester. Further, participants who received 4 or more CAB injections during pregnancy and received at least 4 CAB injections in the year prior to the first positive pregnancy test were also eligible. Cases adjudicated as HIV positive were excluded. However, it should be noted that there were no cases of HIV acquisition to date among pregnant women continuing CAB in the open label extension at the time this analysis was performed. We defined the pre-pregnant period as the time from enrollment to before the pregnancy report date. We used NICHD task force recommendations to define our pregnancy trimester periods. And the postpartum period was defined as the time from that outcome of the pregnancy outcome to 24 weeks after that. Our PK analyses included the evaluation of all drug concentrations from the initiation of CAB through the postpartum period. Participants underwent monthly sampling during pregnancy, and this allowed for greater resolution on CAB pharmacokinetics during the PK period. CAB trough concentrations were averaged within each participant over the pre-pregnant, pregnant, and postpartum periods, as well as within each trimester. And across trimesters, we calculated the frequency of CAB trough concentrations above the 4xPAIC90, or the PK target of the protocol. We also looked at ratios of trough concentrations between each trimester and the non-pregnant period. We also evaluated bioavailable or protein-free or unbound CAB concentrations in the 6 months prior to pregnancy through the pregnancy outcome. So of the 75 participants included in the analysis, Median age, weight, and BMI at the pregnancy report date were 28 years, 59 kilos, and 27 kilograms per meter squared, respectively. All pregnancies resulted in a live birth, with 92% being full term, and participants were well experienced on injectable CAB prior to pregnancy. The median number of injections was 19, with an interquartile range of 7 to 25. More than 3/4 of participants received 6 injections in the year prior to pregnancy, and during the pregnant period, almost 2/3 received 4 injections, with the remainder receiving 5. CAB trough concentrations were comparable during the pre-pregnant, pregnant, and postpartum periods, with median trough concentrations of 2.3, 1.9, and 2.9 micrograms per mil, respectively. However, we wanted to interrogate total CAB concentrations within each pregnancy trimester relative to the pre-pregnant and postpartum periods. This image illustrates an example CAB concentration time profile for a CAB-experienced participant who continued to receive injections during and after pregnancy. Total CAB concentrations are plotted against time, and time is relative to the pregnancy report date. Injections are denoted by the syringe pictograph. The gray shaded region reflects CAB concentrations during the pre-pregnant period, and concentrations during pregnancy are denoted in the gradations of blue. The pregnancy outcome, which was a live birth delivered at term, is denoted by the infant pictograph, and postpartum concentrations are in the shaded region. Dashed lines indicate the 1x, 4x, and 8x PAIC90. And as we can see during pregnancy, there is a decline in total CAB concentrations, with the lowest concentrations being observed in the 3rd trimester, but concentrations increase in the postpartum period. So when looking at total CAB concentration trends from the 1st through the 3rd trimester, median trough concentrations were 2.5 micrograms per mil in the 1st, 1.8 in the 2nd, and 1.6 in the 3rd. When evaluating the average CAB trough concentrations within the context of our protocol-specified target, 100% of participants in the 1st and 2nd trimesters and 98% of the 3rd had concentrations above this level. Ratios of CAB concentrations between the pre-pregnant and pregnant periods were calculated for each participant and then summarized across the cohort. And we showed a decline from 1.2 from the 1st trimester to the pre-pregnant period to 0.9 in the 2nd to 0.7 in the 3rd. As a large number of data points were used to inform that pre-pregnant period, we conducted a sensitivity analysis to only include CAB concentrations within 12 months prior to pregnancy, which reflects more recent product use. So this reflects roughly around 6 injections prior to the pregnancy report date. And what we can see here is that concentration has declined from 1.1 to around 0.7 in the 2nd and 3rd trimesters. In aggregate, geometric mean ratios of the pre-pregnant period to each pregnancy trimester showed reductions of 31 and 41%, respectively. However, the physiologic changes during pregnancy, including declining protein concentrations, increased plasma volume, and increases in metabolizing enzyme activity, such as UGT1A1, of which CAB is a substrate, can lead to decreased CAB exposures. So while several of these physiologic changes may result in decreased total exposures, bioavailable or protein-free CAB concentrations may not be affected in the same way. So we developed and validated an assay to measure protein-free CAB from ultrafiltrated plasma. From a bioanalytical perspective, we needed to consider a number of parameters, specifically sensitivity, because CAB is 99.8% protein bound, primarily to albumin. So we shifted our analytical measuring range around 500-fold for a lower limit of quantitation of 0.05 nanograms per mil. We also removed all of that protein bound CAB using a 10 kilodalton molecular weight filter. So this chromatogram is showing free CAB or bioavailable CAB at a nanogram per mil. And we've actually applied this assay to evaluate free concentrations in our pregnancy PK cohort, and we're actually presenting those in a couple of weeks at CROI. In the last briefly couple minutes, I wanted to transition to discussing LEN for HIV prevention. As we know, LEN is a picomolar first-in-class capsid inhibitor with a multi-stage mechanism of action. Based on in vitro studies, the protein-adjusted 95% effective concentration is 4 nanomolar or 3.9 nanograms per mil. Early simulation studies with the 927 milligram sub-Q Q6-month dosing regimen predicted trough concentrations at the IQ6, or 24 nanograms per mil. The PK trough target for the formulation was the IQ4, or 15.5 nanograms per mil. So as we know, len was evaluated for HIV protective efficacy in the very, very successful PURPOSE 1 and PURPOSE 2 studies, which were unblinded and published in 2024. Len has now received regulatory approval and is a recommended PrEP option, and these data show the efficacy results from the 2 trials. In PURPOSE 1, which evaluated efficacy in Eastern and Southern African women, there were no viral acquisition events in the len arm during the blinded period. In PURPOSE 2, which enrolled men and gender diverse persons, there were 2 cases of viral breakthrough among participants on len during the blinded phase of the study. So within these studies, a randomly representative PK cohort were identified to evaluate len concentrations so we can understand len exposure. What we're looking at here are lenacapavir concentrations over time. The solid gray line indicates the median len concentrations in the PK cohort, and the dashed lines are the 5th and 95th percentiles in the PK cohort. We can see here the IQ1 and IQ4, and what we can see in green and purple are the 2 breakthrough infections from PURPOSE 2. In the first participant, len concentrations are really above what one would expect, above that IQ4, and actually range between 24 to 26 nanograms per mil. For the second participant, len concentrations were a bit more variable, declining from around 10.5 nanograms per mil to 5 before creeping up to 15 and then 25 nanograms per mil at the first HIV positive visit. So I don't have a lot more to share on this other than saying understanding potential pharmacologic contributors to viral breakthrough is an area of interest, but it is confounded by the low frequency of acquisition events reported to date. So to conclude, long-acting PrEP agents like long-acting CAB and len demonstrate high efficacy in the prevention of HIV acquisition. Across the 4 efficacy trials, there were very few cases of viral breakthroughs in the background of on-time injections, ranging from 0 in 084 in PURPOSE 1 to 6 in 083, and that includes the first unblinded year. So as presented today, hopefully I've also demonstrated that a lot of work has been done to estimate CAB pharmacologic parameters in a number of settings, which I think has better informed the development and implementation pipeline for the drug. With that, I'd obviously like to acknowledge our sponsors at the NIH for supporting the CAB work through the 083, 084, and 077 studies, as well as additional support from ViiV, Gates Foundation, and pharmaceutical support from Gilead. I'd also like to acknowledge the scientific leadership on 083 and 084, Rafi and Beatrice on 083, and Sinead and Mina on 084, our colleagues at FHI 360, as well as the contributions from my colleagues at the Lab Center, in particular Sue Eshelman for the important work she did in characterizing infections in the CAB efficacy trials, and Craig Hendricks in supporting the PK design aspects of these trials. I'd also like to acknowledge the SDMC, particularly Brett Hanscom, Emily Voldel, and Amber Guo, who worked closely on all of the CAB data presented today, as well as the constant support from our colleagues at DAIDS, in particular Cheryl Swirsky. And of course, I want to acknowledge the 083 and 084 study teams, the 63 sites who contributed to this work, and most importantly, our study participants. Lastly, I want to acknowledge my lab. All the CAB concentrations presented today came from our group, and it's been a privilege to work with them. I think they're the best around. And with that, I'm happy to take any questions.
Great. Thank you so much for your presentation. And Ken's back on. It looks like my camera's not working. But we have time for a few questions, and I'll invite people to either raise your Zoom hand, or if you have that feature, or you can shoot a question in the chat, which I can read out. Or it looks like we have a small enough group. If you can't do one of those 2 things, you can unmute and say hi. So let's see if we have a couple questions last few minutes.
Get the ball rolling, Mark. That was really excellent. For the few breakthroughs with 083, how much work has gone back to trying to see whether any of those individuals might have been in the window period, very narrow window, I know with RNA testing, but there's still a window. and whether these were occult infections that had been suppressed from the get-go with the early exposure to CAB.
Yeah, so we've described this in some of the work that's come out over the last number of years, but we went back to enrollment visits for all of those individuals using like highly sensitive assays, including single copy RNA, to really identify if there were any infections at baseline. And ultimately, at least in the blinded phase, there were four baseline infections. But of the people who received CAB on time, those D cases, we obviously explored, sort of the timing based on, the sampling schema, to identify the first HIV positive visit.
Thanks. I'll read a question in the chat from Aaron Barnabas. Thank you for this question. How should we think about oral bridging and PK for the long-acting antivirals?
Yeah, I think it's a great question, and I think like some of the data that we presented with in the background of a delayed injection can provide some insight. I think that for a long-acting product that may have a long PK tail, depending on where your Cmax is and your individual specific elimination rate, or long-acting drug concentrations can remain above a prevention efficacy threshold longer. However, I think defining what those windows are is an important consideration. And if we know that an individual may be experiencing significant delays in injections, or maybe switching to an oral product, making sure that there is obviously robust oral support and oral PK bridging, I think would be important.
Great. And one more question. Can you kindly comment on any PK data we may be getting out of CAB-LA and people who inject drugs, given that they were not included in the registration trials?
Yeah, so that's a great question. So I think that's probably an area worth further exploration. I believe, in some demonstration trials, people who use drugs are included therein, but doing focused PK assessments in that population, at least to my knowledge, have not been planned yet. There is a purpose trial looking at lenacapavir in people who inject drugs that is being done in collaboration with the HPTN currently. It's HPTN 103 Purpose 4. So that's kind of where we are in terms of that. But I think understanding CAB in a wide variety of populations, I think is helpful.
Great. And I'm going to pose you one last question with a bonus part. So we have a question from our colleagues online. What are the insights in the two viral breakthroughs in Purpose 2? And then just briefly, what are your thoughts about post-marketing surveillance, and what are you going to be looking, what's going to be of high interest to you in the post-marketing surveillance? So the question about the two breakthroughs that were in Purpose 2, and then what should we keep our eye on going forward?
I think I'm as interested in the two breakthrough infections as anyone from a PK perspective. I think it's hard to tease out. I think what we saw was, especially with long-acting agents, there's going to be high inter-individual variability. And I think what we're seeing in some cases is, maybe like an initial decline in concentrations before they amp up. So really understanding those periods and windows of vulnerability, I think, become really important. We obviously weren't involved in the evaluation of those two breakthrough infections, but I think that there would be a lot of value in really looking deeply from a PK and virology perspective. But again, it's two cases. I also think regarding post-surveillance monitoring, I think it goes back to there is heterogeneity and variability with long-acting products. And I think that we now have much greater assurance and resolution about the timeliness of injection administration from the electronic health record, but that doesn't always predict the PK, right? Especially in potential outliers. In some of the work that we've done is we've seen declining concentrations after the first injection before really reaching steady state, depending on the population.
Great. Thank you so much. Well, we are right on time. I know on behalf of Ken and all our participants, we're so grateful. This was a tremendous amount of information communicated really concisely and clearly. And just thanks for your presentation. Thanks to all who attended. And we'll look forward to seeing this group back for the next installment of the series. Ken, any closing words?
Just know that, but the next installment's April 6th. Christine Saros will be talking about behavioral approaches for optimizing PrEP adherence.
Great.
Wonderful.
Thank you all.
Thank you.
Thank you.